My name is Professor Pier Lambiase from UCL and Barts Heart Centre. So the main benefits for the subcutaneous ICD versus transvenous ICD boils down to the fact that one doesn't need to place a lead inside the heart through the vascular system. So if patients don't have a pacing or ATP indication, one can minimize the risk of intravascular lead complications like fracture or infection, endocarditis. One simply offers the protection of defibrillation without those risks. So the Efficacy Subcutaneous ICD Registry is a multinational registry across 11 countries and 46 centres where we've collected data of subcutaneous ICD implantation patients over at least the past 5 years. Longest follow-up is 6.7 years. And this has allowed us to really evaluate the outcomes of patients receiving the device and also device-related issues. So the main findings are the fact that the device maintains a high level of efficacy in terms of cardioversion, at least 98% final cardioversion of VT-VF events. Also, only 2% of patients actually required their device to be converted from a subcutaneous ICD to a transvenous device, whether that was for pacing, CRT, for example, bradycardia pacing, or anti-tachycardia pacing. And actually, most of the complications that did occur were mainly erosion or infection related to the device, occurred in the first few months with a low attrition rate thereafter. We had one patient who had some noise on their lead. It was suspected this was related to a lead problem, but when the lead was removed and inspected, no structural problem was found. So there's a high level of maintenance of lead integrity in the cohort that we implanted. And interestingly, we found that a number of patients have self-terminating episodes, whether these are appropriate sensed episodes or inappropriate episodes, and these can actually predict appropriate and inappropriate shocks. So this gives us an opportunity really to highlight the fact one needs to monitor the patients carefully, potentially with home monitoring such as latitude, so that you could spot these events early and then avert certainly an inappropriate therapy by device reprogramming or even lead repositioning if necessary. So although in the Effortless registry we haven't had any lead fractures, it is recognised that in a small percentage of newer models of the lead that there have been some lead fractures. This is only at the level of about 0.2%, and certainly something that's being monitored very carefully. And these lead fractures could lead to inappropriate shocks. These are all subject to advisories at the moment and obviously will be monitored accordingly. Well, that's an interesting question because originally we started implanting these devices in very young patients or patients who'd had lead complications such as fractures or infections, and we wanted to target that population early with this new technology because this was a clear gap in availability and requirement for these patients. But essentially any patient now that doesn't require a transvenous lead should be considered for pacing. And the question for subcutaneous ICD, because the question we really should ask ourselves now is, why not implant a subcutaneous ICD? Because one is potentially offering the complications of a transvenous lead without the necessary benefits. So we would certainly recommend it in primary prevention patients with ischemic or dilated cardiomyopathy if there's no evidence of conduction disease, and secondary prevention patients where there's no clear pacing indication or sustained monomorphic VT. So a significant proportion of patients. Well, the battery for the generator lasts 7 years on average. The lead longevity seems to be pretty sustained at the moment. This is 5-year data, so we need much more time to evaluate the 10 or 15-year outcomes. There's been a very small percentage of newer models of the subcutaneous ICD lead that have had some issues with noise or fracture. And this is really due to a change in the nature of the manufacturing of the lead, which the company are addressing. So the main conclusions are the fact that the subcutaneous ICD is safe and effective. It certainly effectively treats ventricular arrhythmias. It has a low level of complications in terms of inappropriate shocks, many of which can actually be mitigated by device reprogramming. And the utilization of a smart pass filter to minimize T-wave oversensing further enhances that. Well, the main thing on the horizon is to allow more tailored therapy, particularly for patients, for example, who subsequently may go on to recover a pacing requirement, whether that's for bradycardia or ATP. So essentially a modular system which utilizes a leadless pacemaker, which can then be implanted in a patient, communicating with the subcutaneous ICD, which could potentially enhance also diagnostics for inappropriate sensing. But also if the patient had monomorphic VT, the device could command the pacemaker, the leadless pacemaker, to deliver ATP, and of course the backup pacing for bradycardia.